Hey guys, welcome back to QA Podcast. Thank you so much for tuning in. So I'm sitting today with a very young doctor, sports medicine doctor. His name is Dr. Sumanth Nayak. If I'm not mistaken, he has taken care highest number of sports cases, sports injury cases in Karnataka. So today's topic is sports medicine. I am pretty sure sports medicine is not just for elite athletes. My intention with this podcast is quite simple: to make sports medicine knowledge really accessible to all the general public out there. It can really help you live longer, have more functional bodies, maybe even avoid injuries that slow us down. I mean, sports medicine is not just for athletes in a way.
Yeah, sports medicine is definitely not for athletes. The word sports medicine was given in general.
Right.
So you said it right, that sports medicine, I am a sports surgeon, but it's not only about the surgery. So sports medicine, which comes in play where sports medicine is prevention, sports nutrition, and rehabilitations, prehabilitations, and even to a point where mental coordinations. So all those comes in sports medicine.
Nice.
If someone does a best surgery and a suboptimal physio, that surgery will be a failure. And if some doctor does a suboptimal surgery and the best physio later, they'll have a reasonable outcome.
Better than the best surgery and poor. Okay.
Exactly. So rehab physio takes a vital role post-surgery as well. We're not talking about it much, but definitely it plays a vital role. You rightly said in the starting, where sports medicine, where it's just not about sports surgery. It could have been a sports surgery, like arthroscopy and sports surgery. But it's not about only sports surgery. It's about medicine as well. Because it's prevention, it comes under prevention, nutrition, conditioning, and the rehab. So that's why it's sports medicine.
So what do you mean by conditioning?
I tell you to go play a sport. Your muscle is not conditioned such way. Where if I tell you to go play football, until unless you do warm-ups, you condition that particular muscles which is involved in that. Your chance of injury is more. So you need to condition your particular muscles for particular exercises. Otherwise, there is high chance of injury.
So this whole thing encompasses sports medicine.
Sports medicine.
Right. I think, okay.
So nowadays, there is what we have done is orthopedics, first MBBS, then MS Ortho, and then fellowship in sports surgery, arthroscopic and sports surgery. But now, in certain places, there is a separate fellowship of sports medicine where they're not operating, where they're just studying about all this sports medicines.
That's a rightful career. Look,
I think
considering
another few years that's gonna be
booming career.
Yeah.
Considering the number of people taking active role in sports from the young age.
Active role in sports, I would say even nowadays 50-60 are running marathons,
right.
ultra marathons.
So what is the unique wisdom a 70-year-old marathoner would have than that people can get the knowledge out from that marathoner than just looking at the fastest sprinter who is very young?
Hydrate, exercise early, sleep well, definitely work on weight training.
But how their bodies can age so gracefully that they can even run at that age?
I think they have treated their body well, first thing. Second would be a good diet plays a major role in these. Because 70 years doing marathon, I think I've not heard about so much about 70 years running a marathon.
Right.
But I think somewhere they are.
There are people running.
There are people.
Right.
I think they would have treated their body well.
They're conditioned.
Their condition, like maybe they treated their body like a temple.
Which is a hard thing to do.
At present scenario.
Yeah, so many distractions out there. So what's the one piece of common sense injury advice that actually makes injuries worse and that almost everyone believes?
See, after you have a fall, rather than resting, you get an advice, you play more, the pain will go away.
You play more, the pain will go away.
You start walking, the pain will go away. You have those niggles, They're just going for playing more and their pain will go away. The second one would be, I think, massage.
What about massage?
After a fall, we get many of the patients, they just go in and massage themselves. And they come in with a lot of swelling.
Okay.
So I think that is one thing, a myth where massage.
Okay, let's explore that. Why does that happen, swelling, and why is it bad?
After a fall, the first body's mechanism is to bleed. Anywhere in the joint or anywhere else, the first thing is bleeds. If you have a injury, a ligament injury or a meniscus injury, the joint bleeds. Until unless you give a rest, there's something called as a RICE protocol, where you rest, ice it, good compression and an elevation.
Okay, RICE protocol.
RICE protocol. There are new protocols of peace and love also, but then RICE is wherein you rest it off, keep ice, put compressions with a crepe bandage and elevate the limb, the injured limb. Rather than this, people early or friends or they go to a bone setter as well, still, where they just massage and they come up after 4 days, 5 days with a huge swelling. So what happens primarily when you have a fall is once you massage, your joint becomes warm. So once it becomes warm, what happens is your vessels dilate in the sense it increases in size. Then what's happening? A lot of blood is pooling in that particular area. And then you keep on doing it over the day, throughout the day, and then it just accumulates.
Blood accumulates. Okay.
So as a sports surgeon, I think one thing I can tell is if you have a fall, rest it off and maybe splint the limb. And if you, due to some reason, if you can't go anywhere you can just ice it, rest it, and then come for evaluation. See, what the compression does is it doesn't allow more
blood to get into the
exactly.
joint. Okay.
And elevate. So once you elevate, what happens is the blood goes back to the heart.
You have to compress on the both side. You don't know where the blood is leaking from, no?
You always compress from below upwards. The rationale behind is if you do the opposite, there is high chance of blood coming and settling down.
So don't massage.
Definitely
follow
no massage.
this protocol.
Definitely don't massage.
Any other things that's a common sense advice people follow, but it is really harmful?
If X-ray is normal, everything is normal. See, if X-ray is normal, our joints are not just made up of bones. We need to understand that if you consider knee, after a fall, they'll go to a normal place where they'll see it happens maybe in the night, where they go to a place where anywhere the duty doctor or someone sees the X-ray, or they just go to a clinic, they'll take an X-ray, everything is normal. So, but it doesn't mean that everything is normal. In the knee, there are a lot of ligaments, there is meniscus, there's cartilage, where usually ligaments, there's damage. So what is happening is they just see the X-ray and everything is normal.
They just look at the bone.
Bone, exactly. They just look at the bone and tell everything is normal. Sports surgery itself is something different because we are not dealing only with the sports people. We are not dealing with only athletes. We are dealing with a general population where weekend warriors is just going in for playing. So we deal with all that. Even a housewife or they're just doing homemakers or they just trip and fall. We're seeing those people as well. Even ankle sprains. So with ankle sprain, if you don't rest it off initially, if you don't take care of it in first 3 to 4 weeks, you will have something called as an instability later on. See, any ligaments has capacity to heal, which some of the ligaments heal, has capacity to heal within 3 to 4 weeks. If you come after maybe around 2 months, 3 months, and then tell us to put a plaster or a walking cast, even if you put, which I don't advise, even if you put, it's not going to heal because the capacity of the ligament which has to heal has gone. So first initial 3 to 4 weeks is very important.
In ankle sprain.
In ankle sprain, because we're talking about general population, I think ankle sprain is the one everyone would have gone through it.
Right. Climbing up the stairs and trekking.
Heels.
Right.
You're wearing 6-inch heels.
Correct. Right.
They're wearing 6-inch heels. Maybe they wouldn't have worn for almost a month. And suddenly you are saying you're wearing 6-inch heels.
Correct.
Our ankle is not meant for that.
Right.
So your muscles in general become unstable. So that leads to your regular ankle pains.
So what to do when they slip out of the heel and they have an ankle sprain?
I would say, yeah,
immediately what to do?
The rest therapy. The rest therapy is the best therapy.
So they don't have to move; they have to keep their
Exactly. In ankle sprains, your X-ray is normal.
ligament is torn.
Exactly, the ligament is torn. When they come in for an X-ray or when they come in for checkup, immediately the knee will be swollen. So, like what you tell, we splint the limb. Splint the limb, maybe putting a slab. You can see, you have seen the cement. Now we have a splinting.
What is splinting?
Splinting is just immobilizing the limb.
Okay, so that you don't move.
Exactly. We don't move. So, see, ligament heals only if you're placing back to its particular area. So, in this ankle sprain, the first 3 weeks to 4, like I told you, first 3 weeks to 4 weeks is very critical. Otherwise, they come with a constant instability. Like you feel that your knees are unstable. Like something is popping off. So, that is when these ankle sprains are deadly. Because after that, even if you cast them, put them on a plaster or do physios, they might not heal.
So timely care is really
Timely
important.
care is very important in any ligamentation, not only for the ankle. There are not many ligaments which heals, because if you consider ACL, which I deal on a daily basis.
Where does ACL happens?
So in a knee, I think I can.
Yeah, show this one. Huh?
So if you see this is a thigh,
Right.
and this is your shin bone. So our joint, see, when you talk about bone, it's not just about only bone. We talk about ligaments, we talk about tendons and joints in general. So this is a thigh bone, this is a shin bone. Our joints are able to move easily and stable. The reason behind it is your ligaments. So ligaments are like rope-like structures which has capacity to have some amount of elasticity.
Like a rubber band.
Exactly, like a rubber band, but it's not that elastic. I would say
come
a
back
rope.
to its position.
I would say like a rope.
Okay.
So you can move around. So that's why it is stable. So in our knee, we have 4 main ligaments, that 2 outside the joint that are called collaterals, and 2 inside the joint that's called as cruciates. So cruciates, why it's in the shape of cruciates. So in that, the most commonly torn ligament is your ACL, what we call as an anterior cruciate ligament. So ACLs usually tear even if you walk down the stairs and if you have an awkward fall, ACL tears. Okay, ACL is one ligament which doesn't heal without an intervention. Okay, if there's something called as a medial collateral ligament that we call as an MCL on the inner side of the thigh. So that, if isolated ligament, only that is torn, that has almost 70 to 80% capacity to heal on
Itself.
The reason being, it's outside the joint. Your ACL is inside the joint. And there's something called as a PCL. PCL is posterior cruciate. Anterior in medical term is front, posterior is back. So the PCL usually tears when you have accidents or when you have a fall from height. So that's one of the strongest ligament. So coming to an ACL, where it doesn't have, even ACL or PCL doesn't have capacity to heal on its own.
Intervention is needed.
Intervention is needed, but again, that's not emergency. It's most commonly seen in football injuries, where people have an awkward fall and then they come in telling that they have a lot of pain at the same time. It need not be operated on the next day or same day. So the main thing would be, first would be the RICE therapy. So immediately after the RICE therapy, maybe after 5 days, the swelling is gone. Once the swelling is gone, you start with a rehab protocol, what we call as a prehab. Prehab in the sense, you 5 to 6 days your knee wouldn't have been moving. And then suddenly you can't operate. I mean, you shouldn't operate. So once you start the prehab therapy, your joint is moving, it's mobile and it's flexible. So once you achieve those prehab necessary requirements, then you can think about surgery after 3 weeks. But rest assured, ACL is not an emergency surgery. If you have an isolated ACL tear. Coming to meniscus, what we call is a cushion. You can take a bush, little bush. My bush is torn, So we have two. One is on the inside, that is called as the medial meniscus, and outside.
It reduces the friction, is it?
It is a shock absorber.
Okay.
See, I like to give cars example. See, we have 4 tires. The same way we have 4 ligaments. And to that, we have shock absorbers.
Right.
Meniscus also play the same role. Whenever the basketball or the volleyball after the smash they're landing, they have an impact. So this decreases the shock to the knee.
If the impact is more, it breaks the meniscus.
Breaks.
Okay.
So impact is more. One thing would be when they fall. If the impact is more, there will be a lot of the meniscus tear. See, when you smash or when they shoot, when they fall and they land, if the impact is more, the meniscus tears. But if they land and if they have a twist, like an awkward twist, then there is high chance of a ligament tear as well.
Okay. And does meniscus heal on itself or intervention is needed?
Again, the meniscus is like a C shape. Okay. We have 3 different zones. Outside the joint is called as a red zone, and towards the inside is called as a white. The red being there is a blood supply. So at the red zone, if the size is very small, if you rest it off, it heals. But otherwise, if the tear is large, it definitely doesn't heal. And meniscus tears not only there one area. The meniscus, like I told, is a C shape. At starting, meniscus tears in one particular area, and slowly over a period of time it extends. And then what at last it will happen is something called as a bucket handle. You have seen the bucket handle? So if you consider that as a C, so on either side of the bucket handle it is connected.
Right.
So what is happening is your meniscus flips. So you have connections for the meniscus to heal only on the 2 sides. The whole of the meniscus is without blood.
Almost dead.
Almost dead. That is one where I would advise a immediate surgery. Not like an emergency now. A bucket handle with an ACL is when a immediate surgery is advisable.
Priority.
On a priority. Ignoring an ACL is something bad. See, now normal ACL takes around 20-25 minutes. It's not about the time, but if you and after an ACL surgery, they are going back to gym by 6 weeks. But if you consider ACL with a meniscus, because of delaying, first you would be walking with the full weight only after a month. You're back to gym only after maybe 3 months. That's again depending upon the extent of the meniscus injury.
If you had to distill the wisdom of sports medicine into lessons for the general public or even recreational athletes, what would those lessons look like?
Good warm up.
Before any activity.
Before any activity. See, you need to, like I told you, you need to condition the muscle. You need to condition the joints. If you're going after maybe a week, like I told you, spoke about weekend warriors. You're just going after a week, you just, because nowadays more of a time slots where you have 1 hour of play. So people just go in without warm-ups. So warm-ups are the main thing which would prevent injuries. Let's not talk only about injuries. Warm-ups are main not only for sports, even for gym, warm-ups are very necessary. You need to spend at least good 10 minutes working on warm-ups for that particular joints, whichever you're playing. At least 10 minutes.
Condition.
The word conditioning and stretching is 2 different things. Okay. Because I was talking about the general population.
Conditioning is for athletes.
Conditioning would be for athletes or anyone who are going pro. Pro in the sense...
Push the max
exactly.
to the limit.
Exactly. You are conditioning joint so that your joint handles it. If I'm taking 30-40 kilos of bench press, I wouldn't be going today or just when I started. I would have gone from 5 to 10 to 20 to 30. And it doesn't happen overnight. Maybe 6 months, 8 months or 1 year. So you're conditioning the joint, your muscles, your tendons, your bones to handle that much pressure. Then your coach, your trainer comes in play, where they would know how to condition those particular joints. First couple of years, take for example any of the athletes, Why the injuries are more prone after 2 years or 3 years or 4 years? Because first year they would have got just by running, practicing by themselves. But over a period of time, they are maturing from amateur to pro. So then your joints are taking a lot of load. So that is why the injuries are more prone once you are 3 to 4 years down the lane. So that is when your coach comes to play, because he will tune it. He'll tune the joint to that particular training, that particular amount of stress your joint is going across.
So that is one conditioning, like the wisdom. So any other wisdom?
Hydration is required for anyone. I mean, again,
Simple thing, but all of them fail.
See, why do you have soreness? Why do you have those cramps? That's because you are not hydrating yourself. That is why hydration during the workout, before the workout, and after the workout is very important. See, if you consider bone health, our bone is made up of bones, joints, and muscles. For bones, we need to work out and make it stronger. For your muscles, we need to condition, and for the joints, we need to keep on moving so that it remains flexible. So that's how you can not live longer. Maybe to do all this, you need to have a
functional body throughout your lifestyle.
Okay. Yeah, you need to have a good functional body where you need to work out at least 3 or 4 times a week. Working out is not just going and telling that I've done 1 hour of walking. See, 1 hour of walking is just, you are hardly burning 200, 300 calories, which is nothing. So to burn proper calorie, weight training is very important. And weight training, it makes your bone stronger. So once it makes your bone stronger, you have good muscles, strong muscles, which in turn decreases the load on the bone. See the US or Western, even with their normal sports, they have incorporated your weight training. But here we are just going and just jogging, running. We are not incorporating weight training in the sports session. I think which is very much important.
I don't think you don't require equipment for weight training. You can use your own weight as gravity,
so
and right?
Calisthenics.
Right, calisthenics.
But that's only to a certain point. But after that, you would require weights. See,
you said about bone strength. Like if you lift weight, it would increase your bone strength eventually. So is there any other way to increase the bone strength?
Calcium is very important. Your major deposition of calcium happens before the age of 20. So after that, it's more about maintenance.
You shouldn't lose the calcium from the bone.
Exactly.
Okay, that is a problem for women. Do men also have the same problem?
See, there's something called as Wolff's Law in orthopedics, where form follows function. That means how much we are loading on the joints, so much amount of new bone is formed. So imagine if you are sitting throughout the day or lying throughout the day, how much amount of calcium, maybe with food or with supplements, how much amount of calcium you are taking in, bodybuilding is not required. So until unless you load your joints, you keep moving around, you do exercises, so much amount of new bone is formed. So that is why exercise is very important. So that is one aspect of the bone. Another would be there's something called as a vitamin D3. So even if you have calcium with your food, if you don't have vitamin D3 in your body, that particular calcium is not taken into the bones. So vitamin D3 is like a carrier. Vitamin D3 in present scenario, most of the people are deficient because you are all the time inside. You don't see vitamin D3 is made by sunlight. Those from morning 9 to 1. Even if you are 20 minutes of exposure, it does wonder. But now we are always inside.
You can't get it from artificial light.
You can't.
Okay.
See, supplements, we do give supplements. So always it is better to investigate, evaluate, and then give them with supplements. After age of 30, every decade you lose 10% of your muscle mass.
Interesting.
A 60-year-old can't be coming in and asking me how to build your muscle or how to be stronger then. So they need to have a good weight training exercises, or exercises in the sense you're not going in on every day 7 days of the week, at least 4 days of the week, some kind of exercises, weight training which keeps your muscle mass, any kind of exercise. Even after a certain point, maybe Zumba, nothing against Zumba, but you need to reduce your weight and then go into certain.
And muscle mass, like if it is lost, you can't be regained, you mean?
After certain point of your age, after certain age, you can't. Because at 60 years, you have not been doing anything. And suddenly if I ask you to do 30 kilos, 20 kilos, 30 kilos, would you be able to do? Might not.
Right. So if you keep on using your muscle through doing exercises, then there's a less chance of muscle loss.
See, how does the muscle grow? If you push your muscle, you push weights incrementally on a weekly basis. Otherwise, that's called an hypertrophy. Your muscle hypertrophies.
What is that? Okay.
Hypertrophies increase in size. Atrophies decrease in size.
Okay.
So if you keep on doing some kind of weight training exercises, your muscle builds. But if you don't, your muscle atrophies.
So what do you think people make mistake here? Do they just stick to cardio, just stick to... Well, what is the right balance, and how do you decide the right balance between cardio and weight training?
I think it's...
Depends on the intention.
Depends on an individual. See, a person who is thin, I think for them, cardio is again, they not do too much cardio. They just need to start with the cardio, have a good mobility, good flexibility, and then they can go in with the weight training. Again, it's their preference. How do they want? Not everyone wants to be bulky.
Right.
So I think, again, stretching on the point of trainers, coaches, I'm not getting anything, but all these people, they have done those things day in and day out. So they know how to prevent those injuries. I'm not telling anyone to, I'm not telling you to have it throughout your life, the trainers. But for the first few years, first few months, I think they will definitely help you. I mean, shape you.
Correct. That you won't make mistakes in your form and also prevent injuries.
Exactly. Rather than taking a trainer later, I mean, to reach, see, if you're again a bodybuilder, you want to go pro, all those, it's fine. Talking about general population where they've just started, see, health is a good investment.
Right.
So they need to invest in this to avoid injuries. And then they blame on the gym. And they blame other people that because of the gym I got back pain, I got this injury. So it's because of the form. Hydration, form, sleep, all these things.
And over motivation. Suddenly they get motivated.
Exactly. It's over motivation,
right.
maybe.
Or maybe urgency to achieve that suddenly, right?
Urgency to achieve would be leading to steroid intake.
Tell me about steroid intake. What's your take on steroids?
There are two types. One is which we give to reduce inflammation. That's called as a corticosteroids. The other part would be those anabolic steroids. Those are testosterones. So urgency to make the body. This urgency to make a better body fast. But it's a slow poison. You will be achieving a lot of things faster with respect to body in case of testosterone. But the after effect would be, when it comes to sports, it'd be a tendon injury.
How excess testosterone leads to tendon injuries?
Your muscle wants more. But your muscle can't hold more. You have that surge of testosterone, but your muscle can't take it. There are a lot of first tendon injuries, liver, kidney damage, high risk of strokes, and cardiac events.
Testosterone. Do you happen to see them a lot?
Yeah, they're open about it. You do not drill them that, have you taken? If you just ask them once, they do tell us. Because it's good for us to know that when have they taken. because your quality of the muscle won't be that great.
How do you deal with testosterone, like people who had taken testosterone and they ended up having a tendon injury?
So any kind of tendon injury, it needs to be repaired or operated.
You have to replace the tendon.
It not replace, you need to repair it, put
Repair.
it back to its place.
Okay.
See, maybe connect with the bone. If two ends are still viable, suture it back.
Got it.
See, you are 25 times your normal testosterone.
Oh, they inject that much.
Yeah. It is 25 times your normal testosterone. With certain urge, like I think post workout or post climbing something, you have that happiness or the urge or adrenaline. Imagine you have 25 times or more.
Oh, I thought it's just double. I'm pretty curious, like if you inject testosterone, how would your body change gradually?
They have so much amount urges, they have so much energy, and they just want to lift. So that's something called as a roid rage. I've just read about it where you have so much anger where they shift it in the gym.
Got it. Oh, that's where they overload the
See,
muscles.
your muscles are, see, when you induce a testosterone, when you inject yourself, it is into 25 times your normal testosterone.
Right. You
So-
should be like a bull,
Exactly.
right? At that amount.
Exactly. So you need to remove it somewhere, and they remove it in the gym.
Because the desire to reach that body is more than their
Reach that body faster.
faster. Patience is not there.
Maybe one thing I would recommend is the proteins, the whey proteins. But now, whey protein has become so at large where the fake are coming into play. They might put in a flashy brands, but it's a fake. Whey protein or any proteins, when we're talking about supplements, because first would be proteins when you talk about gym. You would require, normally would be 1 gram of your body weight. So I think 80 kilos, you would require 80 grams of proteins
Every day.
every day.
Even if I work out or without.
If you work out, it is 1.5 times.
Oh, okay.
Okay. So in those cases where if you can't reach with the food or with your diet, then whey protein, a good whey protein is advisable.
Got it.
But I think it can be reached with the diet.
That. How much egg? How many grams egg has? 6 grams.
6 grams.
Oh my god! I have to have. If I have to consume egg, then I have to have
So
more
you
than.
do not have only egg. You can take eggs, 3 eggs in the morning. You can have a fish, which has 21 grams.
Whole fish.
Whole fish. See, your protein powder, 1 glass of protein has 21 grams. I think if you just eat a fish,
21 grams.
21 grams is achieved.
Mm-hmm.
Chicken breast, it's almost 21 grams again.
So that would give a good muscle strength.
Exactly.
So though you don't miss
See-
out on muscle after you age 30.
See, if you work out and you don't have adequate proteins, it's more like you're not building up the muscle mass again.
What happens when you work out but you don't consume enough protein? What
You are
happens
not seeing
then?
results.
But strength would be increased, right? But there is no.
See, there is no muscle for you to increase the strength. You can lift, but you should need to have muscle to lift later. Yeah, maybe 2 kilos extra, it's fine. But we're talking about post 10 kilos jump. You can't lift it. So if you're working out, again talking about hydration, your sleep, and protein intake.
What if it's other way around, where you don't work out but you have high protein?
You're damaging your
Kidney.
kidneys.
So both has to go hand in hand.
I think everything, it should
Yeah.
be optimum.
Right. How about intermittent fasting?
Intermittent fasting, they talk a lot about 18 into 6. That's about how much gap you're having.
What is it again? 18
It's
into 6.
18 into 6.
What does that mean?
That means you're taking 18 hours of break and you're consuming in between that.
Okay.
It can be any permutation combination.
So 18 hours, no food.
Yeah. In those 18 hours, if you're just because you're starved 18 hours, you're just having whatever you want. Again, you're not going to achieve anything. If you don't have a proper intake, a well-balanced intake, you're going to lose on your muscle mass. So at last, your muscle mass is the most important so that your muscle has strength, which in turn decreases the load on joints.
Mm-hmm.
You can do your intermittent fasting, but in those time when you're eating, if you're having well-balanced diet, I think that you're doing fine. That's my take on intermittent fasting.
So you have to have balanced diet.
You need to have a balanced diet when you're consuming the food.
And why people do intermittent fasting? In what ways it would help them?
I've seen many of them start intermittent fasting because they want to lose weight. See, losing weight, it's more about your calorie deficits. Let's keep it simple. You're consuming
Less calories.
You're going to lose weight. Again, it doesn't happen overnight. It is on a weekly, monthly, then you'll get to see the results. Because you're having a calorie deficit where you have a less calorie deficit on a daily basis, which leads to a big number at last. Calorie deficits along with an exercise will give a better results on your weight loss. So that's my take on intermittent fasting.
Athletes balance between strength, mobility, and endurance. For ordinary people, what's the right balance we should strive for?
Strength and mobility.
Not endurance much.
Endurance is not required.
What is endurance? Endurance is doing so much of things in a short period of time without losing form.
Have you seen high rocks?
Right.
I think there's a lot of fuzz
I
about
just
high
saw
rocks.
some reels
Yeah,
around.
so those are endurance.
That means you can do it for a long time.
You need to do it for a long time and a short exercise, but you lose a lot of calories. So that's endurance.
Okay, intense activities, huh?
It's a high intensity training. That's endurance.
Not the duration of the activity,
No.
just the high strength, high intensity. Okay.
Yeah.
So we don't need high intensity, right?
We don't require.
Mobility, how would you increase your mobility?
Start being couch potato. Keep walking. If you're sitting for long, you know all the issues happen.
Right.
People start getting back pain.
Am I sitting in the right posture? Now I started getting anxious.
Sitting in the right posture, sitting for some time is fine. But sitting for a long time in that posture is bad.
How long?
Maybe an hour.
Okay.
See, when you're sitting for an hour, I would advise you to get up,
Move around.
and then come back. See, again, moving around, you're walking, that's a cardio.
Right.
Once you're walking, your joints are moving, indirectly become flexible.
Yeah, you were saying sitting is dangerous for a long period of time. So you have to walk around, then sit, and then standing desks are better, right? Standing desk. What's your view on standing desk? I think it is picking up in the Western countries, right?
Maybe again, too many things are bad. So if you're sitting for 1 hour, walk around. If you're standing for long, again, you're standing in one particular position.
Right.
Again, after that, just walk around for some time. Standing, maybe the same concept of why they have done is you're sitting for long, you can change the position and you can stand for some time. That's the whole concept of it.
How to increase the mobility of the neck, shoulder, and other parts? Like you have to keep exercising, rotating.
You need to stretch it. Stretch the joint for how much you can. See, if you're considering, it starts from the wrist. You need to do this, and then you need to all the other positions, and then coming to this would be getting it here, slowly lifting all this. So coming to shoulder, getting it here, just going throughout their range of motion, moving all around how much ever it can.
Any degrees?
Yeah, any degree.
What is recover in depth? Like body getting back to its original form?
Body would have taken a lot of blunt. So it needs the time to recover. Your muscle may be working hard, so it needs time to recover. Where we are not giving it much time. But If you see in Western, they'll do, nowadays I think even here we'll do a lot of ice bath.
Right.
So ice bath is a good recovery.
Oh, it works.
It
It's not a
works.
fad.
No, it works.
Mm-hmm.
It works, but here recovery, we are talking about an injury or recovery post-workout. So these are two different things.
Mm-hmm.
See, recovery post-injury is a physio,
Okay. Recovery post-workout is
a different.
right. So why it's important to recover post-workout? What happens if you don't recover and keep on?
Injuries.
Injuries. Okay.
Injuries.
So recovery is essential to
Re-
prevent injuries.
Exactly. Your muscle would have taken a lot of stress, lot of strain. So it needs to recover so that it can work again. If I tell you to work for 24 hours, you can do it for a day, maybe not for the second day. So the same way for a muscle, if it needs to give you results the next day, for you to lift more weights, it needs a recovery. So for that, hydration, sleep is very important.
So and you said the cold bath, ice cold bath.
Ice bath.
So how does it really help recover? Like what happens when you immerse yourself to the ice tub? So how it really affects the recovery process molecularly, or
I think it's more about once you dive in the ice bath, your vessels constrict. So less amount of blood is falling there, going towards the part, and in turn causing recovery rather than causing pain.
So inflamed vessels
Constrict.
constrict.
Yeah.
Okay. So there's a less supply of blood vessels, and muscles will come back to its original form, like how they were. I mean.
It not original form, but then the main pathway of the pain is gone.
Okay.
See, the substance P, what we call as, which causes pain, less amount of substance P is reached there.
And is recovery is just for muscles, or even joints have recovery of its own?
Anything which is
Bone also has
anything which
recovery
is
of its
going in for load requires recovery. I think sleep take care of it.
For most of the recovery.
Most of the recovery, sleep take care of it. See, we are keeping it basic here. Hydrate, sleep. That's the two basic things.
Is ice still the gold standard, or are there any better ways to handle minor injuries today?
See, ice, usually it is for an acute injury. If you have a fall, immediately ice it.
What happens exactly?
So again, the concept of once you keep ice, your vessels constrict.
Okay.
So less amount of blood is flown to the particular area. So in turn, your swelling is reduced, and once the swelling is reduced, swelling is, it increases your joint. So it increases your joint capsule, which causes pain. So what the ice does is it constricts, less amount of blood is flown to that particular area, and in turn decreases swelling, in turn decreases pain. So for any acute injuries, ice is the best. Chronic, like an inflammation, like a spasm, in those hot packs, hot fermentation is better.
Right.
So again, they talk about which is better for you. But for acute condition, ice is better. For the chronic, again, there is a recent talk about which is better for you. I think you can do hot and cold packs. Alternative hot and cold packs. But again, for me, in my practice, for acute, ice. For a chronic, it is hot packs.
Many of us spend hours hunched on the desk, working from home, scrolling on phones, and it's killing our backs and necks.
See, when you talk about posture, sitting in one particular place, in one posture is bad. See, when you talk, IT profession, we get a lot of patients who has a desk job coming in the back pain. It's only about you are sitting in that position for a long time, in turn causing your back muscles to be less strength. I mean, it becomes loose.
The condition for that position only.
Exactly. It is always you're in crouch position. What is happening? Your front part is taking a lot of load, and you having a back becomes less strength. So in those cases, what happens is you start having disc problems. So disc is nothing but like how we have cushion in the knee, the same way we have cushion in between your spines. So what is happening is once you have a lot of pressure in the front, the disc has to come out somewhere. So it comes out and starts pressing on the nerves. So that is when you get something called as a sciatica, or you tell you have a numbness. So that is when you start getting that pain. So in those cases, definitely back strengthening, core strengthening is very important. When you're sitting for long, after an hour, get up, walk around, do some kind of activities, do some strengthening.
Is there any other game-changing posture tip that you would like to share that would help regular folks to avoid pain and stay strong? Just
Sit straight.
Sit straight.
Sit straight. Even to a point of not having your neck. Every 5 degrees of bend puts almost 5 pounds of load on your neck.
Interesting. Wow. Okay.
So when you're sitting like this, you're around 40 degrees.
Right.
I think you can calculate how much amount of pounds are falling on your neck.
Oh, right. That's how I got small bulge here in the spine. Small.
I think your now spine is like this.
I mean, I've seen other people's neck hunch like this.
Exactly.
That's extreme, but not. I mean, that. How is that developed? Again,
That's
with
always
the weight,
seeing
right?
this. Now phones are the big things.
Right.
Because I was just seeing somewhere, maybe 30 years down the lane, we'll have this arthritis. Because we're using fingers that often.
Right.
So we are always seeing this. So posture correction is main. I think doing some kind of exercises at the end of the day solves most of the things.
Even bad posture.
Yeah.
So what to do if they have problem with the neck? Like, as I said, they have a bulge and neck would be like this. And I've seen some of my friends, because of bad posture, lack of exercise, they have a hunch.
So hunch, I think that's a little too complicated once. So once you reach that stage, it's a little too much. But to avoid that, neck strengthening exercises are very much important. I mean, it's too simple. I think you can sit in your chair and do it. It's nothing but just take it all throughout your... Okay. And just move all and rotate yourself full.
To the max, no extreme.
Yeah, just rotate. It's just taking you to all the range of motion. Exactly. And then this comes now, your movements are done. Now coming to strengthening. Would be just hold it like this, push it down.
What to push?
No, just you are resisting coming out.
Okay.
The same way on the opposite side.
So I have to push neck to this
Yeah.
side, I have to push hand
Yeah.
to this side. Okay. So what does it do?
It strengthens your muscles.
Do you think supplements are overrated?
Supplements.
Or are there any few essential even non-athletes should consider?
I think we spoke about calcium and vitamin D3. So again, those things are after investigations, after checking. But with respect to supplements in my practice, it's a very less, I would say, painkillers. It's more about supplements, where again, supplements is only for a short time. We give a lot of collagens, type 1 and type 2.
In the form of tablets?
In the form of tablets.
Okay.
But again, those are mostly post-surgery.
For the tendon recovery?
Exactly. For the tendon healing or the cartilage healing. See, it doesn't heal that like how we advertise. Again, supplements are controversial. Why would I give this? Our joints are not moving that well in the first initial part of our surgery, like a month. So what this does is this gives an supplementation of the collagens. But after the second month, third month, I never give. So once your knee is mobilizing properly, movements are fine, then we can stop, because the knee gets its nutrition when the movement is there. If there is no movement, there is no nutrition, joint becomes loose, wear and tear it starts, and then your osteoporosis.
If I take collagen, I don't have any injury, would it improve my tendon strength or ligament strength or something like that?
I wouldn't advise with respect to that.
Okay, so collagen is one of the supplements.
Yeah,
Is there any
collagen.
other supplement list?
Omega 3. Again, those I would advise only if you're into sports, you would require supplements because you are putting your body through so much. You would require supplements. But if all these you're getting through your diet, I mean, nothing like it.
Chronic pain management. So this is the big concern I have. I've seen elder people can't walk, like chronic knee problem in the like knee joint. They walk with the stick. Can you avoid getting to that stage even if you're genetically prone to?
See, Indians are genetically prone to knee osteoarthritis. In that, females are most common for osteoarthritis. See, again, genetically means we don't know how much we can prevent.
Right.
We speak about body weight, high BMI. Only those people get osteoarthritis because of weight. You might have heard she has knee pain because of weight. But we have a lot of patients who are not obese, who are proper BMI. They are getting osteoarthritis. So I think this can be answered only genetics. Or if they would have had an injury with respect to the ligaments earlier. So that is why it has led to this, where your knee becomes unstable, where if they feel like I can't, there's no balance in the knee, and then they lead to a point of getting an arthritis. So that is a degenerative arthritis.
So how to treat them?
Again, in that we have 4 stages, where fourth stage is where your two bones are rubbing each other, where bone on
It
bone
make noise.
exactly. So bone and bone contact is there. So in those cases, there's what we do is called as a knee replacement, where we remove some part of maybe 6 to 8 mm of your thigh bone, 6 to 8 mm of your shin bone, and replace them with metal and a plastic
Lubricant is added.
in between. So it acts like your new joint. So that is in case of your
Degenerative.
elderlies. Yeah,
Okay.
degenerative. So if a patient who are 50 years, the knee replacement in those is not advisable, because once you replace your knee, maybe after 15 years or 20 years, depending upon your how you go about it, how you abuse your knee post surgery, or your activities after surgery, it depends upon 15 to 20 years. If you replace your knee at 50 years, after 15 years, he's 65, he or she is 65, you're going to replace again. So it's called as a revision replacement. You wouldn't want to do that. So in those cases, what we do is, if it's a grade 3 osteoarthritis, in those cases, if you see their knee will be bent, I think you would have seen a lot of patients who are knee will be bent. So if they're 50, 55 or good bones, even 58, in those cases, what we do something called as an high tibial osteotomy, where we correct the alignment of the bone. I give an example of car. Even if you change the tire, after changing the tire, you're going to see the alignment. If you're changing the tire and not correcting the alignment, you're going to have wear and tear of the tire in that particular place, one place. The purpose of doing an alignment post putting a new tire is that it has an equally balanced
Wear and tear.
It's not equally balanced wear and tear, equally balanced
Load management.
Exactly. So in the same concept in this, where the knee would be bent, and normally if you consider the alignment is straight. So in those cases, when the knee is bent, your load is falling inside somewhere. So in those cases, what we do is something called as a high tibial osteotomy.
You align them.
Exactly.
Right.
You align it and we get the knee back to its alignment, so that again the pressure is falling back at the center or little on the outside. Because osteoarthritis is not reversible. We have to replace, because the wear and tear is already started. We can't replace it. We can't reverse it. What we are doing by this is, from one position which is already wear and tear has happened, we are shifting it back to its straight alignment.
So, what's the preventable trick here? That if I take care of if I'm prone to have those situations later in my life, what trick from sports medicine I can apply to postpone it or never go through that painful things?
After 30,
Mm-hmm.
you would have at least every 1 decade you have 10% of your muscle
Muscle
mass
loss. Mhm.
loss. So in those cases, I think early weight training would be the better option. See, what does weight training does is makes your muscle stronger, indirectly causing less load on the joints.
Mm-hmm. Okay, then cycling would help, right?
See, walking,
Mhm.
cycling, and swimming. These are the best exercises for elderlies. Elderly in the sense who are above 50. Yeah, marathon runners, they might tell that no, we are doing this. I'm talking for a normal population of an elderly who who want to prevent injuries. So for them, walking, cycling, and swimming. Cycling and swimming, to be precise, that's good for the joint because at water we are buoyant, so there is less load on the joints. So if you see aqua treadmills, so what it does is it takes the load away from the joint. So indirectly less load on the joint, but your joint is still moving.
Mobility is there.
Mobility is there. So at 60 years, you can't expect your joint to be fine because your joint wear and tear would have already started before.
So you mean either increase the mobility of the joints or strength of the muscle?
Strength of the muscle start early. Start early in your life.
That is.
Yeah.
And cycling, like, when you cycle and when you imagine cycling, you think a lot of friction in the joints, right? So if I'm genetically prone to degenerative arthritis, wouldn't cycling make it worse?
In the cycling, there's a lot of technicality where your seat needs to be at this particular height.
Correct.
Your seat needs to be at the height of your pelvic bone. So all that matters.
Right.
And we have seen that people in the gym, they are at the full resistance. So that is when your knee is getting in trouble.
Because of the bad posture.
And postures.
Bad load management.
Exactly, bad load management. Where, see, for a operated individual, we don't advise any resistance. We advise them at no resistance, normal movements. Why? It's only for the mobility. The same way for the elderlies, we are not expecting them to have a quad strength of a 40-year-old. We just want their joint mobility to be good. So that is why your cycling and swimming is important. So swimming also, we don't advise them to go for around 10 laps. Some movements are there which is not causing load on the joint.
All right, before we get into the next chapter, take a break. Change the posture, go for a walk and go. Can you share a story of an athlete who came back stronger from an injury when it seemed almost impossible?
Rishabh Pant.
Okay. Tell me end to end of this incident and what the process he went through for the recovery and how was his performance compared to pre-injury?
I think we all seen the crash. I think the car was totaled, but he was lucky enough that he didn't have any other injury, head injuries or any other injuries. But from the sports surgeon aspect, his knee was dislocated. So what is dislocation is when your joint is out of its place. See, joints are kept together by ligaments. So for a joint to dislocate, you need to have your ligaments torn all over the place. So when you talk about Rishabh Pant, his knee was dislocated with all the 4 ligaments torn. I
like
spoke
completely
about ACL, PCL, the collaterals, all was torn.
Completely separated.
Completely torn.
Okay.
And
it was just hanging.
Yeah, because once the connection it's not a fracture, but it's a dislocation where the bone is not broken, but his ligaments are torn.
Bone to bone connection is gone.
Exactly.
Completely.
So there is no stability per se. So once the bone is dislocated, joint is dislocated, he can't walk. And it is not like once you put back the joint, it's in place. Like in shoulder, if you put back it in place, if there is no bone piece or no fractures, it's okay to continue for once. But not the same case in the knee. You need to get it sorted out. So like I told you, the ligament doesn't heal on its own. So his ACL, PCL and both the collaterals were gone. So it needs to be operated. Now how do you operate? For 4 ligaments to torn, you need a graft. ACL doesn't heal on its own. So you can't repair. You need to reconstruct. For a reconstruction, you need an extra graft. So by graft, what you mean? It's a tendon. You need to have a graft removed from the hamstrings, from the quadriceps, and
Graft
from the
you mean
patella.
part from other parts of the
Other
body.
part. So that's called as an autograft, where you take it from your own body. If you're taking from someone else's, it's called an allograft, a cadaver.
Mm-hmm.
So now we have something synthetics. So that's also the newer trends, where it's like a polytape, polyester. So we put it as a synthetic graft.
Interesting.
But in his case, I think it was all autograft, his own.
Oh,
Okay. But that's okay for a single tendon to tear. But in Rishabh Pant's cases,
all 4.
all 4. So you require graft from all over the place. So in those cases, we can remove from your quadriceps. You're not removing all the muscles. You're removing one part. And then we remove something called as a bone patella bone. That is, we are removing from this. See, quadriceps, you're removing from this part. Bone patella, we are removing from this. And hamstring from the back. So when you require more, you can go for the other knee.
Wow. Okay.
So in his case, for him to get back to this level of sports, where post his century is doing somersault, I mean, the surgeon who had operated might have got an heart attack also. That is one of the most inspiring story.
Even the surgical wise, now how did they decide to craft 4 different?
No, we do that. See, our center is a trauma center. So we get those kind of...
But wouldn't it affect the other function of
Not
mobility of the
Not at all.
body?
So we are not removing all the tendons. When I spoke about quadriceps means quad means 4. We are not removing all. We are just removing one part of the tendon and not a bigger length. We are removing a smaller length. And when you remove hamstrings, you have 5. We are removing only 2. So the function is still there. And we are going to the same on the opposite part.
Nice. But would they have the same level of mobility after grafting?
With a good physio, definitely they can go back.
So you mean Rishabh Pant had greater physio? I mean, you would credit Rishabh Pant's recovery on having a great set of physio or his training pattern after surgery than the surgery itself?
I would say it is a team. A good surgery or the best surgery with the average physio, the patient might do an average. But with the average surgery, with the best physio, patient would still get a reasonable outcome. Even in I would say 40% is the surgery, rest 60% is the physio. Whenever a patient comes to me post-surgery, they ask, is everything will be fine? I would say our job is just to operate. Post that, it is your and the physio's job to get back and making you the better version of you.
Do you recall what kind of training of physio Rishabh went through to get back to that form? It took him 1 year, right?
Normally, if you want to get back to sports after such injury, first of all, it's a dream. Normally, it would take not less than 2 years. But he got back to cricket, not talking about the professional, within 1 year. So 1 year is normally we tell patients with a single ligament surgery. That took 9 months to 12 months. But in his case, all the 4 ligaments were gone.
What's the secret? What was different here? Is it his body or is it his discipline or his team?
First would be the planning of the surgery. When to do.
Why that matters? When to do? Why not immediate after the accident?
Immediately after an accident, any ligament surgeries are not emergencies. Even if it is a dislocation. See, dislocation is an emergency. If the knee or a shoulder is dislocated, it has to be put back. That's an emergency. The surgery, definitive surgery for dislocation, it's not emergency. Post a dislocation, it's considered a knee. Your knee would be swollen. There's something called as a capsule, which is covering the knee or any joints. That would be torn. So any surgery which you're doing will cause stiffness post-surgery. So it is always better to delay or do any definitive procedures after 10 days in case of dislocation, when surgery is mandatory. But in same, when a single ligament is torn, it is always prehab and then advisable after 3 weeks. So I want to stress on a point that no ligament surgeries are emergency until unless it's a dislocation. Even in a dislocation, dislocation has to be reduced, but any definitive procedures again can be done after 10 days. Some surgeon would do staged. They might do 2 ligaments first, and then after 3 months they might do 2 more. But surgeons with an expertise, they can do all 4 in a single stage.
So in
post
Rishabh's case, it was single stage.
Single stage, because they have to get back to sports faster. And post that, without his determination, it's definitely not possible.
Nice, very interesting case. Any other cases like that?
Again with Bumrah, he had a ACL tear. It's a single. I mean, in footballs, it is most common.
ACL tears,
ACL
right?
tears. It's most common. When in case of Bumrah, single ligament, he got back in 6 months with an ACL.
So I read a quote somewhere. It said the difference between a 6-week recovery and a 6-month recovery often comes down to what an athlete does in the first 6 minutes after an injury. And most athletes get it completely wrong. So do you agree with that?
With respect to athletes, the first 6 minutes, I mean the 666, first 6 minutes, because
That's an evil number again.
6 minutes would be, I think they first need to know that some problem is there. After an injury, they should not go back immediately into playing. Let the team coach or the team physios, they need to assess it. If they're not fit enough to go back to sports or to go back to field, I think that is where it decides whether 6 weeks or 6 months.
When they go back to the field, they intensify the injury,
Exactly.
right?
See, if there is a partial tears, if I tell partial ACL tear or a small meniscus tear, which need not require a surgery, they go back to play and they might first increase the size of the tear or complete the tear.
Oh.
So maybe the quote is based on that.
Do they feel the pain, right?
Definitely.
During the
Yeah,
small injuries?
They do.
They
Because
still-
any injuries inside the knee causes inflammation. Inflammation is nothing but swelling. Swelling leads to pain.
So it's not that they won't get to know there's an injury or not. It's obvious they get to know, but they don't want to express they are injured. Okay, why is that?
Because they may be off the field for another 2-3 more matches.
They won't get the payment.
Exactly.
Okay.
Payment, no. But then sports is more about the
play.
adrenaline, the play. So maybe because of that.
That is the biggest mistake you think.
Not only for athlete, for any of the weekend warriors who are playing, that's a mistake.
So what are the most common sports injuries you see here? And also in the professional league?
ACLs. ACLs and in the shoulder.
Shoulder dislocation.
Shoulder dislocation as well.
How about hamstring strains? Do you
Hamstrings.
deal with them?
Hey, hamstring strain, we deal a lot. That again would be just non-operative. First, again, any injuries, rest it off. Because any hamstring strains can lead to tears very often. If you don't rest it, let the inflammation subside and then do stretching and let them go back to sports.
How does hamstring strains happen? Like which sport particularly?
Any sports, if you don't stretch, even if you're going for a long run, if you don't stretch it, your hamstring strains.
How does it feel like that pain?
It's like a catch. You are not able to extend your knee further. So that's more.
That means you can't walk.
You can, but with
comfortably.
pain. You would have discomfort when you're extending your knee.
And what is the treatment for that?
Arrest it.
It will get back on
Ice
its
it.
own, is it?
Maybe once the pain is better, then you can stretch it back. Then you're back to normal.
Warming up before the sport
Warm up.
would reduce 80% of
The injuries.
injuries. So concussions, do you take care of concussion or you do send to somebody
it's
else?
a ER. Concussion is always dealt by ER. Lucky enough for me, we don't deal with emergencies.
So that's common in sports injuries,
It's
no concussion.
not most common, yeah.
But
it's
American NFL,
NFL,
and
those are contact sports.
right, long-term impact on brain, right? Even if it doesn't show up, then it's like
It does show up.
yeah.
It does show up. With some vomiting, headaches, it does show up.
Okay, let's get into ACL tear in detail. So I hope, guessing that's your specialty in.
Yeah, that's the highest cases we see on a daily basis. And that is one of the highest surgeries done in sports.
ACL tear.
ACL tears all over the world. See, the ACL tears when you have not conditioned your muscle to take that impact. So it tears when you land awkwardly.
I mean, parachuting, and if you land wrongly,
Yeah.
you get an ACL tear.
Yeah. Maybe.
How is the impact? Impact is
there's
perpendicular
something
or
called as a pivoting. Pivoting in the sense when you run towards a ball and you just want to kick in one direction, but you twist and you pivot. So that is when your ACL tears. Or when you are going towards a ball or someone tackles, more like a contact. So that is when your ACL tears. It's a ligament which is in between two knees. So it is a thigh bone and a shin bone. So that is which is keeping it stable. So if it tears, you feel like something is not fine, something is unstable. My knee feels like slipping off.
It's not painful, you mean?
Initially,
just
it is,
uncomfortableness.
Yeah, the first 1 week to 10 days, it is
painful.
So post that, once you start doing rehabs, once you go to a physio, then the pain subsides. When pain subsides, when 3 weeks, then the patient might think that
it
is nothing, he's recovered. Whereas that is when most of the people do the mistake.
Oh, that's dangerous, right?
So when a simple ACL tear, which can be sorted out in 20 minutes, 30 minutes, where they are taking that knee, abusing it, going back to sports with that knee, and they are destroying the meniscus or damaging
shock
the meniscus
absorber.
more. It's a shock absorber. So imagine a car with 4 tires. Now there is only 3 tires because one tire is damaged. You have a shock absorber at the same side. So your car is going normally in a straight road, it's fine. But when there is a pothole or a hump, that is when you require your suspension or a shock absorber. So when you have that impact, your shock absorber is taking all the loads, and that is when your meniscus tears. So the long-term effects of meniscus is, the next would be a wear and tear of the cartilage. So cartilage is nothing but the covering of the joint. Both the bones have a covering called cartilage. So that once that is torn, that is when you get arthritis. So that is nothing but the wear and tear of the joint.
Are people here aware of ACL tear, or do they keep on abusing, and what stage of patients you get to treat usually, like most often? Is it in the initial stage of ACL or the arthritis stage of ACL?
So the athletes, they do come in that early stage. They might not have only ACLs. Because of the impact or the amount of the damage has happened, they might have a meniscus as well. But if you see an isolated people, that is people who are coming with only ACL tears, in those athletes are more because they are knowledgeable. Their friends or their colleagues, coaches, they are aware of it and they advise them to get it sorted early. Because when it's just an ACL, after the surgery, you are going back the next day. So what we do is an arthroscopy, the keyhole surgery, where we are just doing a tiny incision, a small incision
on the knee.
Or anywhere for the ACL on the knee. So we're putting a camera, seeing everything, dealing everything with the camera, and then pain is less. A misconception of arthroscopy is that patient won't have any pain.
Without any anesthesia.
It is with anesthesia.
With anesthesia.
Arthroscope is a minimal invasive and it is a surgery. Any surgery does have pain. So it is just a method of doing a surgery. Earlier they used to open it. In open, what we are doing, we are cutting the skin, we are cutting the subcutaneous tissue, then we are cutting the muscle, and then going and reaching the diseased part, where we are removing most of the normal things to reach that is why your arthroscopy helps you, where we are just making tiny incisions, the minimal invasive, seeing the affected parts, seeing the affected part as a whole, and then we are sorting it out. So less pain.
How big is the incision? In the size of mm?
It's
centimeter.
Maybe a centimeter. Maybe a centimeter. But to remove the graft, it's almost 3 centimeters. We remove the hamstring graft.
With just 3 centimeter incision.
3 centimeter incision.
Wow.
So talking about the ACL surgery, it's just a day. The next day they're home. Physio starts immediately. And they are back to gym, not the contact sports. They are back to gym in 6 weeks. Physio is the must. Contact sports is 8 to 9 months.
Minimum.
But if you delay to a point of having a meniscus tear, first, with respect to ACL, they can walk the next day. I mean full weight. But when it comes to a ACL with a meniscus or only a meniscus tear, at least depending upon the tear size, at least 1 month they are not allowed to walk. They can walk with a walker, they can bend the knee, but they can't bear the weight and walk. So that is the reason we tell it is always good and better if you do when you have an isolated only ACL tear, not people ignoring it to a point where they get a meniscus tear as well. And once you delay a ACL surgery, there is wasting of the knee, wasting of the quadriceps. So
what does that mean?
Wasting in the sense the size of the quadriceps decreases.
Okay.
So indirectly your muscle doesn't have strength. So if you are delaying it to a point of 6 months, you can imagine how much of the muscle mass has gone. So to recover that muscle mass 100% it might not be possible, but to recover up to 70 to 80% it takes a good 2 to 3 years.
Why does this impact on muscle mass?
Because you're subconsciously not putting weight on this.
Oh, okay. You are very careful.
Exactly. You're very careful. You know, see, normal walking is not a problem with the ACL tear. We are talking about when you're lunging, when you're playing any pivoting sports, or when you're going for treks. So that is when you require ACL. Normal walking, we don't require ACL. We require, but then for day-to-day activities, no.
You don't need to go through surgery.
You might not. See, some of the patients might not require if they are just doing household activities, or people who are above 55, they might not require ACL reconstruction.
I like the procedure you take, the endoscope. I mean,
Arthroscope.
Arthroscope,
So,
okay.
Arthro is the joint. Scope is the camera what we put.
Right. Where do you know exactly where to make incision and where to lead and look for?
So it takes a lot of...
Now, what's your intuition? Like, what's your, like,
No,
if a patient comes with the ACL tear, what's your first thought running in your mind as a surgeon?
So first thought would be assess. Like I told you, ACL is a ligament. We don't see ligaments in an X-ray. Always an X-ray is a mandatory. Like we spoke first, all X-rays, if X-ray is normal, it need not be normal. There is ligaments, there is meniscus. So first is always an X-ray to see if any fractures are there. Then before that, examination. Examination is very crucial.
What examination?
Examining your knee. Okay.
With camera.
No, it's just
Mobility.
perceptions. It's just touch.
Where does the pain?
Exactly.
You ask the
Where
patient.
is the pain? In case of ACL with meniscus, see, like I told you, after 3 weeks, ACL patients might not have pain. They have instability. That they might tell doctor, whenever I'm walking, I feel like something is unstable.
Not right.
That I'm not able to balance it properly. It is giving away. So these are the complaints they come. But patients with a meniscus tear, when we examine, they'll have pain on the affected side whenever we touch. So that's the examination part. To confirm, it's always an MRI. So MRI tells us where exactly is the tear, ACL tear, meniscus tear. MRI is the test. Now comes the explaining part, where we need to educate patients that first your ligament is gone. Your X-rays are normal, but your ligament is torn. Whereas you will be able to walk, but to do heavy activities like running, jogging, climbing up the stairs fast. So for all those, your ACLs are necessary. The surgery is not emergency. If you're coming on a day 1, see now most of them athletes, they come here, but patients who are coming already 3 weeks, so those are separate. I'm talking patients who are coming with a twisting injury which happened just now. So if they are coming, educate them that this is not an emergency surgery. So this I'm talking on a isolated, if the patient has only ACL tear.
So ACL with the meniscus is a very immediate surgery.
Yeah, in meniscus also again it's not emergency. But ACL with a particular type of meniscus tear, that is a bucket handle, again it is not emergency that I have to do it now. We can rest up, but I wouldn't wait for 3 weeks. The reason for waiting for 3 weeks is it is a recent injury. Patient will have a lot of swelling, blood. Swelling is nothing but the blood inside. If you're doing surgery, first we can't see that well in the camera. Second, there are good studies that if you do it early, that patient, there is a chance of developing stiffness. So the whole point of surgery is lost if the patient develops stiffness. So that comes the patient education, that it is not an emergency. I will immobilize the limb, that is splinting the limb, and after 3-4 days you will be starting to move your knee. That is called as a prehabilitation, where you are advising them to start moving again, firing up the quadriceps, because they are not walking the quads, they wouldn't know how to fire up. So with the prehab, what we are doing is we are teaching them how to bend the knee again, slowly, gradually, to a point of within 3 weeks they are almost near normal.
This is before surgery.
Before
right?
surgery, near normal in the sense with respect to pain.
Mm-hmm.
See, the patient has not gone back to their normal activities, the pre-injury. We are just talking about post-injury. Patient is just starting to walk. After a ACL tear, if the pain is not much, patient can walk. Patient is allowed to walk. But if there is a small meniscus tear, we had few patients where they sit down for food. So after second week, she has sat down, and then she came up with a bucket handle meniscus, where she didn't have it in the first place.
Oh, it can happen.
Yeah, see, what happens is when normally when you're sitting down, you're like this.
Right.
So when you're getting up, what is happening is you are putting your whole pressure on the meniscus. For a normal meniscus, it's fine. But for a meniscus which is partially torn, there is definitely a lot of load, and it leads to a bucket handle tear. So the first 3 weeks, patient is allowed to walk, do normal activities, but I wouldn't advise them to deep squat.
Okay, how do you operate?
So after 3 weeks, or whenever the patient is fit enough in the sense, patient
Doesn't feel pain.
Pain might have, but I'm talking about if the patient is able to move his knee beyond 90 or up to 90, that means patient has a good knee mobility. Why is it important? Because post-surgery, patients should move their knee. Because if the patient is coming with a stiff knee, the whole purpose of doing the surgery is lost. Because not like earlier where we are keeping the knee, putting plaster or putting the belt, keeping it for 1 month. No. After this surgery, patient is bending the knee next day. Patient is walking with the full weight.
So, how do you repair the ligament? Do you graft here as well, or just change its position to the right?
There's something called as a repair. There's something called as a reconstruction. Repair, we are just stitching back the ligament or any tissue. That's called as repair. Reconstruction is we are replacing it. We're putting something new.
Synthetic? Or allo from the cadaver?
No. In India, we prefer same side autografts. That's the samely we have hamstrings. My go-to is hamstrings. For an athlete, we can even go for a patella tendon. But for my go-to is hamstrings.
Why there's a stark difference between athletes' patella tendon? Is it because the procedure is expensive, only athletes can afford it?
It is not expensive. With bone patella, bone. See, the word itself is bone patella, bone. There is bone attached to it.
Right.
Here, what we do is we remove a part of bone from here. We remove a part of bone from the kneecap. And it's a slightly open surgery where we remove, and this is a ligament. So bone is there on the either side. So bone to bone healing is faster. And they are going faster into their sports.
Just because they can get back into ground faster. Bone patella.
Because sports career is smaller.
Right.
Okay, with respect to general population, for them, hamstring is sufficient enough.
How do you take hamstring tendon? Again, they have to do minimal invasive incision and take the tendon out. And
so there's no extra incision. We are going to take the hamstrings from the same place where we are going to do a drill in the shin bone. So that is why the size is 3 centimeters. Rest maybe 1. Here it is 3. What we do is repair. ACL repair they do, but not many. And it has to be done in an acute stage. Acute stage means within 10 days, 2 weeks. But the repair, the studies are controversial. But reconstruction is a gold standard, where you take a hamstring and you do a tunnel in the thigh bone, you do tunnel in the shin bone and fix it. So fixing is with a button, titanium button on the thigh side, and with a bioabsorbable screw, meaning it dissolves on its own within 18 to 24 months.
So that's the finishing of the surgery.
Yeah, and they discharge the next day.
And they can walk immediately after the surgery.
Immediately after the surgery, again as tolerable.
After the discharge.
They can, as tolerated, they can walk.
So what not to do after ACL surgery?
Not run.
Not run.
Not run.
For how long?
Running after an ACL maybe 2 months. All my patients, I tell 50% is my job, then 50% is
your job.
yours and physio's job. See, physios play a critical role. We see them during surgery, post-surgery, but they are in constant touch under physio care for the rest of at least 3 months.
And what would physio do to the
physios
to get back?
Would be first, they will get the knee moving. Movement of the knee post-surgery is critical. Some of the patients are anxious that they have pain. They're still of olden era where they have done surgery. Keep it. Don't move. So they're still in that. So in those cases, physios play a major role.
To motivate them.
To motivate them, get their knee moving, to start firing up the quadriceps. They wouldn't have been using it this much. So physios strengthen quadriceps, teach them how to walk again. There's something called as proprioception, where it's a knowing where is a joint in a simple way. In a common man's word, joint sensation. Where exactly is a joint when you're walking? So there's some proprioception where we have mechanoreceptors. So when an ACL is gone, that is also lost. So it takes at least 2 to 3 months for connection between your new ACL and your body. So they don't know how to walk. They might have difficulty. So physios help them throughout and they get them back to their sports. After 4 months or 5 months, there is, depending upon what all we do, there is getting back to sports also, where there are certain exercises, wobble boards, strengthening, abductor strengthening, all that is a part of that regime.
Athletes would go through different type of physio.
Yeah, because they can have for a common man, we have many different things. But for an athlete, they are in that almost 18 hours a day. Doesn't mean that you need to spend 18 hours on that. We're talking, they can divide themselves, have a good nutrition, workout, treadmill in the mornings, do strengthening in the evenings. But as a common, they don't do much.
Right.
They are busy with the other activities.
Is there any landing mechanics that, like if I'm falling and suddenly I should have a landing mechanic so that I don't break
There's
my
no
ACL?
landing mechanics, but what we spoke on conditioning. So if we talk about landing mechanics, then all the football players should have. You would have seen all the cricket players nowadays jumping, going in for dives. So in those cases, everyone should be having that. But it's more about conditioning the knee or conditioning the ankle or conditioning the hip.
Not to have ACL.
Not to have an ACL tear.
How would you condition a knee?
It's by strengthening the knee. It's by letting know the knee that I can have this kind of movements.
We can expect this kind of movements. So how do you decide return to play decision after ACL tear? Return to play when is it a sports physiologist?
It's a standard of 8 to 9 months. For a single meniscus, for a single ligament tear, it's 8 to 9 months. First 1 month would be just normal movements, physio. After 6 weeks, they can go back to the gym activities. Gym would be cycling.
Weight training?
No weight training.
Okay.
No weight training because their muscles are still not fired up. So weight training is after 2 months and it is gradual. And after 6 months, they can go back to a normal sports, not contact sports. And after 9 months would be any sports, professional as well.
It's healed.
Healed.
What is the risk of them tearing the ACL again?
It's close to 10 to 12%.
Oh.
That's high.
So then they are psychologically impacted not to give their whole, right?
In spite of doing a picture perfect ACL, at least 30%, 35% don't go to their previous injurious state.
Just because of psychological pressure.
It could be psychological that it might tear again. Second, it could be muscle imbalance where they wouldn't have done physio when it is required.
Interesting. I think we have covered ACL to great depth. Okay, shoulder injuries. So what happens exactly in shoulder dislocation and why it happens? And okay, before that, let's understand how shoulder works. There's a ball kind of socket.
Yeah. So in shoulder, it's more of a golf ball and a tee.
Mm-hmm.
So it is, if you see, ball and socket is a hip joint where your ball is covered with a socket made of bone, but in our shoulder, it's covered all around by the muscles. So if you see here, this is the humerus, this is your
Back.
scapula.
Scapula.
Okay. So here there is muscle all around. There is no bone. So shoulder is one of the commonest joint to dislocate. Is one of the commonest.
So muscle connects the scapular bone to the femur. Okay.
The humerus.
Humerus bone. Okay.
So what happens if a patient or if someone dives? You would have seen Rohit Sharma putting his shoulder back.
Right.
There are a lot of videos where you could have seen in the Indian jersey where he puts it back during the match. So it is one of the commonest joint to dislocate, and if you don't treat it well, if you're in somewhere playing, if it dislocates, your friends might put it back vigorously.
What happens here when you mean put it back?
Put it back. So coming back to anatomy, where this is your scapula, this is your humerus, and we have a rotator cuff muscles. Rotator cuff is 4 muscles where it is inside the joint, which is keeping your humerus, which helps in moving us up, down,
Any
inside
angle.
and any
Okay.
angle. Inside that, you have something called as a labrum.
Again, muscle,
It's a tissue where it acts like a shock absorber.
lubricant.
It's more like a suction, which sucks the shoulder inside, the humerus inside. So the labrum acts like that. So once your shoulder is popped off because of the
Impact.
amount of impact, awkwardly, so your shoulder just pops off. So when it pops off, it takes off the part of the labrum. So when it comes off, your labrum is torn. If it's a first timer, you will come to the hospital, patient will keep his hand awkwardly, and we put it back, then that's again an emergency. Putting back is an emergency. And we do it under anesthesia because patient have a lot of pain. You just can't put it back. People do put it back, but it is advisable under anesthesia because there is high chance of breaking the humerus when you're reducing the shoulder.
Reducing the shoulder.
Putting back the shoulder, there's high chance of a humerus fracture. So that's always better to do under anesthesia. So once you put it back, you're all set. You're set for then. But your main labrum is torn. So coming back, do we require surgery immediately? No. So what we do is we get an X-ray to see if it is reduced back, and then we get an MRI to see if any bone piece is there. Because if the impact is if it's an accident, sometimes the impact will be so huge that it might take off a piece of the bone. So in those cases, surgery is advisable to do for a first time dislocator. But if a normal, again a weekend warrior or someone who's not an athlete, if they have a first time dislocation, surgery may not be advisable, because if the patient is around less than 20 years of age, almost 90% of them have a redislocation rate. So 10% of them have a chance that it might not displace again.
90% they won't read.
See, again, a first-time dislocator on a shoulder is
Under
a
the age of
controversial
20.
topic. So sometimes an athlete, it would require to operate. But if it's a
Common
man, we can try without surgery.
Just with the physio exercises.
Just with a first rest for a couple of weeks. After that, physio, just to strengthen. But there is no guarantee that it might not dislocate again. If it's an athlete, it is definitely advisable to sit with them,
Go under a surgery. Go for a
talk to
surgery.
them that you might have a chance that you will redislocate. If you are off season, you can go in for a surgery, but it is always better to sit with the patient, talk to them that you have a chance of redislocation. You want to get it done, you can get it done. This we are talking only for an athlete, because we see many.
Right.
So sitting with them, talking to them, and telling them what are the complications, what happens if we conserve, what happens if we operate. Because a common man, a 20-year-old common man and 20-year-old athlete is two different things. An athlete wants to go back to his pre-dislocation status, where he's going back to his 100%. But an common man, if he's playing once in a month, he's okay to not play. This is for a first-time dislocator. But patients who are coming with a recurrent dislocation,
Back to back, even
Back
after
to back.
surgery or
no,
without surgery.
without surgery, who are not operated. So in those cases, what happens is every time your shoulder pops off, you are not only damaging your labrum, you're damaging your bone as well, because dislocation is where bone comes and locks. So what happens if a car bumper goes and keeps hitting a wall? There has to be damage on the both sides. The same way, each time it dislocates, you are damaging not only your humerus but your glenoid as well. So up to, again, there is a percentage of bone loss. So how does this bone loss occur is, imagine a car where it goes and start hitting a wall. Each time it hit the wall, there is a damage in the bumper as well as a wall. The same way, when a humeral head comes and locks, see, shoulder dislocation,
There's friction again.
friction, but it is locked. So that is why it is not easy for someone to put it back, because this part has come and locked.
I mean, you can't move, is it?
You can't move.
Okay. Is it
So
painful? when
It's very painful.
Oh.
So what has happened is this, it comes and it locks. So imagine your friend is trying to put it back. So there is high chance that this bone breaks. So that is why always it is better to do under anesthesia. Every time a shoulder dislocation, there will be some amount of bone loss. So once you cross 15% of bone loss in a common man, some people might stretch it to 20 as well, but once they have 15% bone loss, you can't put the labrum back. Normally less than 15%, you can stitch back the same tissue. The labrum, we can put it back. But once you have more than 15% bone loss, even if you put that, there is almost 40% chance it fails, because the main covering of your shoulder is gone. So imagine this is your shoulder and this is your humeral head and this is your glenoid. Normally it is moose, but imagine now some 15% of your 20% of your glenoid is bone loss. So what is happening? Even after putting back, you don't have the surface area, you don't have the coverage. So there is almost 30 to 40% chance that it will re-dislocate even after surgery. So in those cases, we need to put a bone there.
Extra bone.
Because there is a bone loss. So if a patient has 20% bone loss, the 20% of your bone is lost. No point in putting the muscle back. There is no coverage. So in those cases...
So you attach bone to humerus?
No, at the glenoid.
Glenoid, okay.
So in those cases, what we do is, we put... There is a bone here called as a coracoid. We take this off, we put it back.
Interesting.
So we are getting back the bone there.
How do you glue the bone there?
With screws.
With screws, okay.
We have different techniques where we put screws, 2 screws, or nowadays what we do is we put a metal free, like a tape, where you will see some extra bone, but you won't see how it is holding. So those are the newer ones where we put a metal free cerclage.
What's the advantage of that?
It's metal free. I mean, see, if you put 2 screws, there's something called as a bone resorption. Bone absorbs, what we call in a normal way. Bone absorbs. So in those cases, for some patients, there might be metal related issues, screw issues. So that is not there in case of metal cerclage. But gold standard would be a extra bone, a latarjet, what we call as a latarjet, where we put back the coracoid.
That's how you treat recurring dislocations.
Recurrent with a bone loss.
Okay.
If a patient doesn't have more than 15%, who is not an athlete, we do something called as an arthroscopic Bankard's repair. Imagine your glenoid as a clock or your watch. So 12, 3, 6 and 9. Okay. Normally when a shoulder dislocate, it dislocates down, inferior, front and down. So in those cases, your 6 o'clock to 4 o'clock, your labrum is torn. So what we are doing, we are putting the camera, what is arthroscope. You just have 3 stitches, 2 in the front, 1 in the back. So under that, we stitch the muscle back to its place.
So shoulder dislocation is about playing with the position, the original position of the tissue.
It's putting back
back
the original place. You would have seen Rohit Sharma during the match. He throws the ball, his shoulder dislocates. He's putting it back. So that's one of the crudest way of doing it. So I would advise people not to try.
But how he ends up hitting sixes with that shoulder? I mean...
So again, I think the physios are working on him well, strengthening the shoulder. But if he's able to put it back that easily, that means there is a severe bone loss. Because it is going in easy.
So he has to end up with that bone replacement.
Putting back the bone. We are keeping it simple. We are not telling a lot of words. Putting back. If you have more than 15% or 20%, some doctors might extend to 20%. If the 20% of your bone is gone, then you need to place a bone back. Yeah, you can put the stitch of the labrum, but then there is almost 30 to 35% of the chance that they will re-dislocate.
So do labrum regenerate?
It does.
If it's torn?
No.
So labrum's function is lost.
So what happens is, if now we spoke about 6 o'clock to 4 o'clock or 3 o'clock, your labrum will be torn with respect to your watch. So if you don't treat it, if you don't repair it, it's like you have a torn cloth or a torn sheet. If you keep it inside somewhere, it won't extend the tear. It won't tear more. But if you keep on using it, the tear extends. The same way, if at 3 o'clock, it has a tendency to extend to 2, 1. It has a tendency to extend to 6, 7, 8. So that is when you get something called a panlabral repair. Panlabral is the whole labrum is torn.
So you have used it extensively and it has torn.
Exactly. Because in those cases, normally we put 3 stitches. In those cases, we would require 7 to 8 stitches. So what we do is we put something called as an anchor. Like how we spoke about this button suspension in the ACL. The same way here, what we are doing is we are putting an anchor. Anchor is nothing but a stitch. It's a wire. You are stitching. The same way we have a stitch which is called as an anchor. We put it inside the bone and we anchor that stitch in the bone. That's why it's called an anchor.
So scalpel to humerus, is it?
No, it's only in the glenoid.
Okay.
It's only the glenoid because putting it from the glenoid and to humerus makes it stiff. We are just putting the anchor in the glenoid and taking a bite at the labrum and keeping it back to its place.
So would it allow the same degree of movement of the shoulder?
Yeah.
Yeah.
It takes a good time. Same again, 8 to 9 months for them to go back.
Again, after a lot of physio training.
Lot of physio.
So do you recall any athlete who has undergone that surgery and back to the field?
Many other.
It's confidential, is it? Okay. Like even I had an incident back in my degree. I was playing kabaddi and I wanted to show off, that edge in WWE. There was a wrestler called Edge. To defend someone, I edged. What's that move called? Spear. I speared someone, so I ended up dislocating my shoulder.
So in those cases, what I think is it's a AC joint dislocation. AC joint is a collarbone which dislocates.
It was so painful. It was there for one week minimum.
So it more like a collarbone dislocation.
Okay.
So that's again a different topic.
Okay.
So if talking about the redislocation, the first time dislocation, we had an incident in the gym where they dislocated. I went and reduced.
You dislocated.
Yeah.
Okay.
I went and reduced it. I was following him up for 1 year, and the second year, I still remember May 16th, he dislocated, and 2 years later, May 11th, 2 days prior, I asked how is his shoulder because he had come to the gym. He told all okay. I was like, good, a first time dislocation, didn't dislocate again. After 2 days, he called me in the night that it's dislocated again. He was a 23-year-old. There is highest chance that they dislocate. So earlier it was, if a patient dislocates for the 3rd time, then you can advise them for surgery. But now, it's always better to tell the patient that this is the issue. There is high chance of dislocation. If he's an athlete, he can take the call whether he wants surgery or not. But if it's a common, then definitely you can tell that there is a chance that it might not reduce. But fairly less chance.
Only surgery is required only when there's bone loss.
Any dislocation, there will be bone loss. There are many factors which causes redislocation. I don't want to get into too depth where if there is a bone loss too deep in the humerus side, then also if you have 10%, they can have a recurrence. So there is a lot of permutation and combination.
Yeah, right. So how do you decide these things? So there's a lot of variations. No, there are 3 bones, muscles, labrum.
Keeping it simple, if a patient, a common man, 15%, less than 15%, he will get a Bankard's repair. That is putting back the labrum back to its place using a camera.
So you find the position of the bone using that camera.
Yeah.
And you cut the bone using the camera.
Yeah.
And you find location to stitch it using the camera.
We put the screws using the
camera. So you can tilt the angle of a camera, is it?
Yeah, there's a 30 degrees. We have 30 degrees, 70 degrees also. In fact, now we have a better version of it where we were first in the South Asia to have.
In Mangalore?
In Mangalore.
Wow.
We are first in South Asia. So in this, what we can do is we can have 2 different visions in the one single tower.
Single camera.
Single tower.
What's tower?
Single display.
Oh, okay.
So what happens is, normally if you want two views, we would require two different towers.
Mm-hmm.
Some of the places might not have two towers, where we have 4 towers here. But in this 4K system, where I can use only one display and I can see two different places what is happening.
Mm-hmm.
So what it has done, it has made the surgery faster, where I need not change the camera too often.
Mm-hmm. And also make better decisions.
Exactly, better decisions. So precision.
Mm-hmm.
So the multi ligaments, what we told about, the Rishabh Pant multi ligaments. So those are happening faster. Otherwise, there were a lot of times we need to change the camera.
So you need 4 towers for those surgeries.
No. So in those 1 tower, but it used to take a lot of time.
Mm-hmm.
Lot of time in the sense, yeah.
To make decision and to see
operate.
things. Okay.
Because the decisions most of the times are made pre-op, before surgery. Decision making is the most important. So that is most of the time before surgery. So what this, the new system is helping is, first, we are doing the surgery faster. So in turn, less pain and precision. And with one camera, we can make it to 0, 30 degrees, 70 degrees. So like you told, turning, we not turn the camera much.
Nice.
No, it's a honor for hospital and the city, because this is the first in South Asia.
Right.
Earlier we had, which was first in outside Bangalore.
Mm-hmm.
I think 3 years back we had bought. That was first in Bangalore, first outside Bangalore, in Karnataka. But now this time we got first in South Asia.
So I had a shoulder injury, as I told you long back. Now I don't see much cases, but I'm kind of scared it may reoccur again. So do you suggest me to do calisthenics? I'm really pulled by those pull-ups activities, but do you recommend to do pull-ups?
If it's not causing you any problem, you can do, but strengthen your shoulder, warm-ups before that. If it starts giving you pain or discomfort, just show.
Do you see swimmers having risk of shoulder dislocation?
Yes. They are moving the shoulders throughout his range of motion. I wouldn't say swimmers have the highest, because shoulder dislocates at one particular angle, and that angle is throwing.
Baseball players.
Any cricketers also, but they're throwing this. It has to up and it has to go back. So abduction and external rotation. So this is called as abduction. This external rotation. So only at this position, the shoulder pops off.
So you mean speed and the angle of shoulder,
Yes.
both in combination,
Again,
cause the
conditioning. So if your front muscles are not conditioned enough, are not warmed up enough, there is high chance that the front muscle loses its tension. It doesn't tear. I'm not talking about the inside, the labrum. I'm talking about the outside muscle. It loses its tension and it might be loose, so that shoulder comes off.
So if anybody is scared of losing their shoulder, having gone through shoulder dislocation in their life, so they just have to condition.
Yeah. Basically, you're strengthening your shoulder muscles.
So exposing shoulder muscle to various types of rotation angles.
I would say
Like
treat the
conditioning.
shoulder as a one unit and strengthen it.
How to strengthen the shoulder?
Each muscle has its own strengthening exercise.
Okay. So how many muscles are there in the?
See, we are talking about the muscles inside the joint. So that is a rotator cuff, which helps us in lifting the shoulder up, down, side. That's 4 muscles. But you have anterior deltoids, you have lateral delts, you have posterior delts, and you have trapezius. So there are many muscles, but talking about rotator cuff, there are 4.
So you have to activate, you have to condition all these muscles.
All this. So talking about rotator cuff, we get a lot of patients who are elderly, where they tell that we have a constant pain and we have not fallen. We didn't have any trauma, but it keeps on hurting, and we have pain in the night. This we're talking about a 55-year-old, 60-year-old. But in those patients, we see something called as a degenerative rotator cuff tear.
Mm-hmm. It's a genetic.
It's not a genetic. It's a overuse.
Mm-hmm.
Because a lot of overhead activities.
Mm-hmm.
See, over a period of time, like how our meniscus degenerates or anything in the body degenerates, the same way our rotator cuff, which is going in for overuse over a period of time on a daily basis. So in those cases, there is a tendency for it to tear. But if the same tear has to happen for a 40-year-old, so they need to have a traumatic incident like a fall. But in an elderly, they will come to you telling that I didn't have a fall, or I just lifted something little light or something there and it torn. After that, I'm not able to lift. So those conditions are where you will have a rotator cuff
Degenerative.
Degenerative.
Would you say lack of conditioning is again the reason for that, or just aging?
Aging. So that's why it's degenerative.
It's not preventable. It's
Not
just
preventable. It can be, but again, going back, starting
What do
from-
you do in that case?
See, in those cases, if you see again, almost 50% over the age of 55 will have some kind of tears. So we are not going to go and operate for everything. If a patient complains of difficulty in lifting, then they're not able to lift at all, and when we do an MRI, again the X-ray is normal. In an early stage, X-ray is normal. So if you see most of the sports-related conditions or ligament conditions, your X-ray is normal. So in those cases, we see MRI if there is a muscle tear where two muscles are torn. So in those cases, again, we do an arthroscopic rotator cuff repair. But not all patients require this. If they're functioning fine, if they're able to do their daily activities, and if only one muscle is torn, and they're able to do all activities, but normal on and off niggles. So in those cases, we can delay it by, again, strengthening the muscle around the shoulder. But when there are two or more muscles which is torn, and they're not able to lift, so in those cases, we recommend to do a rotator cuff repair. What is repair? Again, getting the muscle back to its place. See, what happens is when they have a slight fall, or a couple of times what we got in the bus, they put a brake. So suddenly it's gone. So in those cases, it's torn. So what happens is over a period of time, it's like a rubber band. If you tie rubber band in two places and we cut at one end, what happens? It springs back. The same way, if this is the front muscle, so it is attached here. What is happening once it's cut from this end? It is come back. So in couple of months, 1 month, 2 months, we can easily put this back. Getting it back, it is easily movable. But after certain points, like 5 months, 6 months, it's a little difficult. So in those cases, we need to see other options. We can't put a muscle back to its place in tension because it's not be too tight, because it tears. It is torn in the first place for a reason, because the quality of the muscle or the cuff is not good. So we can't put that muscle back to its place in tension. So in those cases, if the patient is around 55, 60, so in those cases we can plan for many different things, like putting a muscle transfer, taking a muscle from back, putting it in front, or sometimes we put a SCR. So those are again into depth. That's too much in detail.
Your job is more complicated than I thought.
And we still haven't reached 10%.
Oh. Every sport has its own signature injuries. So you said football has ACL. So I will just mention sports. So you just tell me, list on the signature injuries. Cricket.
I would say back pains.
Okay.
Injury wise, it's ACL, meniscus, and shoulder injuries.
Okay. Cricket.
Cricket.
Football, ACL,
ACLs.
ankle sprains.
ACL, ankle.
Okay.
I would say one is ACL.
ACL, okay. Badminton.
Ankle sprains.
Mm-hmm.
A lot of ankle sprains, and there's something called as a slap. Slap tears are biceps related issues.
Okay.
So for
It's like a
badminton-
muscle tear.
Yeah, badminton, I would say ankle sprains.
Mm-hmm. How do those injuries happen? Like jumping,
Jumping,
lunging?
landing,
Smash. Okay. Running.
running would be calf problems. If don't warm up properly, there is something called as a stress fractures. So that's most common. Stress fractures which happen in the shin bone.
Arm wrestling.
See, arm wrestling is the next sports. We have had at least quite a good number of fractures.
College students.
College students. Fractures.
Okay.
In the humerus, we have seen quite a few.
What happens? Okay, let's see the biomechanics of arm wrestling. What happens when we arm wrestle and where it goes wrong?
So we went in detail where we have found that it doesn't happen when you arm wrestle. It is when they take it back. So
Okay.
what is happening is you're keeping it like this. When you do this, it doesn't happen. But when they suddenly shift it back, that is when
Oh,
it
okay.
cuts.
Interesting.
So we have one of the arm wrestling champions. That is where I asked him.
Okay.
So how does it happen? So that time he told that until unless you lock this, so there is high chance of the fracture.
So that's how you prevent
Yeah.
fractures in arm wrestling. Locking
lock
the.
it. I think don't take my words.
Okay.
I think people can research about it better.
Okay. So you see the arm wrestling
we've
injuries
seen
frequently.
quite a good numbers.
Cycling.
Again, back pains and to some extent knee pains because of improper sitting adjustments.
Right,
That's all.
positions.
Positions.
I've heard about a lot of evidence-based approaches like modalities, recovery modalities like cryotherapy, compression, elevation, PRP, stem cells. So what works, what doesn't work? What's hype?
PRP, again, it's a controversial topic. Stem cells are the new budding ones. Stem cells do have, with respect to the athletes, they do have some good advantage. But PRP, some studies say it is not, some studies say do. We do give PRPs, but that's very rare.
PRP to the injured place?
To the
or-
injured place.
Okay.
So PRP is nothing but patient's own blood. We take it off. We get something called as we centrifuge it. We get a plasma layer, and that plasma, there's PRP which is rich with leukocytes, PRP which is poor leukocytes. So again, depending upon that, we give it specifically into the joints. So PRP has its useful in knees, in ankles as well, but not that much in shoulders. But again, the newer studies are saying that it is not giving much of an advantage or relief.
So stem cells, do you see Indian sports using stem cells or is it just in the lab-based things?
It's in the lab-based things.
Okay. So how does it exactly, it just repairs the injured cells?
Faster.
Faster.
It repairs it faster.
Interesting. So what's cryotherapy? Just ice bucket?
Ice baths.
Okay. Go to Singapore, Switzerland for practice and conferences. And also, like Western countries take sports medicine quite serious and they pay quite a lot. So why did you decide to settle in Mangalore?
Now, Mangalore has always been close to my heart. So, whatever it is, wanted to give back to the society. And talking about Switzerland, where I've done the fellowship, yeah, related to sports, it's very good. The rehab centers, it's very good over there. But Mangalore is the place where we have lots and lots of athletes coming in for surgeries or medical consults. So in those cases, for me, this was the place to settle.
So tell me about your recent knowledge exchange, R&D exchange. When was it last time?
Last time I was in Singapore.
Okay, what did you guys talk about?
So it's not only a shoulder conference.
Shoulder conference.
Only a shoulder.
You guys have a
week.
conference just for shoulder.
Just for shoulder. Just for shoulder. And in fact, sometimes we just have for a replacements. Just for shoulder replacements or just for shoulder soft tissues. What we call a scuff. So we have particular for that.
And you had once told me that you don't take any regular orthopedic cases. You just deal with cases very specific to sports or joints. Why so?
Would you take your Porsche to a regular mechanic or the Porsche service? Sports surgeon or a surgeon who's dealing with ligaments day in and day out, doing those cases 4 or 5 cases a day. He knows, however, he might be young, but he's seeing only those cases. So he knows and he's going for those conferences, seeing only those topics, and he knows what to be done. In fact, even after attending so many conferences, doing so many surgeries, we still think that it's not enough. General orthopedicians do ACLs, but are they doing it right? Some might. But if at all something wrong happens, would you want to go to a general orthopedicians or who are doing sports surgery? So if that surgery fails, would you want to go to a general orthopedicians or would you want to go to a sports surgeon?
Sports surgeon.
Sports surgeon. So why not come to a sports surgeon in the first place?
So how did you got into Switzerland fellowship? Was that something easy or something that you're proud of?
That's definitely I'm proud of because where I've done, they get to see and they treat the Switzerland Olympic team.
Wow.
Everyone doesn't get it. It's only people who are actually doing cases. We need to send them our logs, that how many cases, what cases we have done. So only seeing those type, and then after a year following up, sending our new cases, and then we get that fellowship.
And how was it like when you got the fellowship? Which year was it?
It was 3 years back.
Okay, so
3 years back. Yeah.
So you spent how many days, months in Switzerland?
It was 6 weeks.
6 weeks training.
6 weeks of only shoulders.
So you happened to interact and work on Swiss Olympic team.
Yeah. So
cases
it was 6 weeks of only shoulder and seeing all the different cases of shoulders. And not only that, it was Switzerland's Olympic team as well. We got to see a lot of aqua trainings, rehab centers. One thing I would wish is we get that kind of rehab centers back here.
What's different?
A lot. Starting from the machines, starting from right the time they walk inside, the calculations, the use of electrodes, the swimming pool, the aqua training. They, in fact, the physios, they have a cameras, like a 3D cameras all side. They take the actions to a matter of maybe 3 degrees as well. So it's that accurate.
All
so
biomechanics.
Now, so now you can know that why we go outside, because the publications what they do are that best, where they take in even consideration of single degrees.
Accuracy.
Their accuracy. So in those cases, I like to travel just to see any advances. And you can see me traveling at least once in 3 months just to be at par with the Westerns so that we get the same quality of treatment back in our place.
Nice. So what we can expect 10 years, 20 years down the line, how the field is going to be?
Sports surgery is just started to grow. We're going to see, I think, many more. Now, still the sports surgery is yet to see the robotics. Now the robotics are there. We have a robot here for knee replacements, hip replacements.
Robotic means without human input, just robot handling?
No, human inputs are required.
But just for precision, robots are put.
Exactly.
Okay.
So in those cases, robotics are there now for the replacements. That is now coming in for arthroscopy as well.
Robotics in sports.
Robotics.
Okay.
I have not seen it, but that's the next thing we're hoping.
Right. How much can technology like wearables, motion sensors, and AI-driven analysis actually prevent injuries before they happen?
Yeah, so the motion sensor is the one where The main thing was in the Switzerland,
Mm-hmm.
where they see the
degree
electrodes,
level, right.
the motion sensing, and we are getting it here,
Mm-hmm.
where they pre-injury, how much is the muscle mass, how much is the movements. So all those are sent to the patient as well. It's an app.
Okay.
So we can have to a point of again in variation of 2 degrees. So we can record that and it will be in the data, patient's own data.
Mhm,
And then regular follow-ups, we can know his recovery, how much muscle is grown, how much physio he is putting across,
Mm-hmm.
and everything.
And predict.
Predict, yeah. I mean, it will be good for publications, articles, and
Right.
helpful for making our patients better.
Mm-hmm. Can you walk me through the complication of those machinery behind your back?
We are kept in the OPD where the patients can first-hand experience what is an arthroscope, how it feels to be seen inside. They can first-hand experience that how it feels to put the arthroscope inside the knee in the special bone model. Not only knee, we have it for the shoulder as well, where they can see it in the OPD. They need not be apprehensive that what is an arthroscope, how the TV is and everything. For that, we have special bone model where they can see it firsthand. Because we have a lot of observers coming. Observers are the one who's doing cases on a regular basis. Like that, we have 4 fellows with me who will be with us for almost 6 months to learn. In fact, now we have 2 fellows where it is fellowship by the national board. Till now, there were only 5 hospitals. Now we are the 6th hospital, first in Karnataka to get this. That's a fellowship it's an FNB of sports medicine. 6th hospital in India to have this, where we have 2 seats. And we are the second one to have 2 seats.
Before we end, do you want to crack any myth?
Because you're told crack, I think crack or any sound in the joint.
So, okay, nice.
Crack or sound in the joint without pain is normal.
Okay.
If it's cracking along with pain, then it's a concern.
Thank you so much.
Thank you.
Nice way to end the
Thank you.
podcast.
Thank you.
Yeah.